Absolutely. So it's really interesting because it again comes back to cholesterol. So I think we need to just take a step back and understand that the cholesterol lowering industry, or the fear of cholesterol, is it's a $1 trillion business at least.
Wow.
We know that the total sales of statin drugs have been, in the order of $1 trillion. And that's extraordinary when you think about it. So there's a huge industry around it. There's food industry as well. And what these seed oils do, they do lower cholesterol. But just to quote a colleague of mine, Professor Rita Redberg, who's a cardiologist at UCSF, she's editor of JAMA Internal Medicine. She says cholesterol is just a lab number. Who cares about lowering cholesterol unless it benefits the patient? And when you look at the seed oils, you're absolutely right, Paul. Certainly when when they're heated and for cooking purposes, we know they produce these toxic compounds called aldehydes, which are carcinogenic. And that's really, really bad for the heart, for the brain. It's definitely linked to cancer as well. There is no real benefit at all. It's only harmful to have seed oils, in my view. I don't think that you should be having seed oils at all. They are pro-inflammatory. And I think, again, with his distraction about lowering cholesterol as the primary way of preventing heart disease, which has failed completely, utterly, miserably failed, it's distracted actually from the understanding now that heart disease is a chronic inflammatory condition, which is exacerbated by metabolic risk factors. So it had very little to do with cholesterol, actually, at all. The only reason we have got to this stage is because about 1 in 250 people suffer from a condition called familial hyperlipidemia, and they have genetically very high levels of cholesterol. And those people tend to develop heart disease compared to the normal population. But even in those groups, 70% of women and 50% of men will not develop premature heart disease. And my own research, we'd figured out that it was nothing to do with LDL in terms of the people with FH who develop heart disease versus the ones that don't have no difference in LDL. It's probably something to do with those, a subset of those people who have issues with clotting, etc. So the whole cholesterol paradigm needs to be really broken down. And what I say to patients is I don't proactively, by the way, I've got to be honest here, I'm a cardiologist, and I do not proactively do anything to lower anyone's cholesterol at all, because it's horse shit. It is basically forward science. It's bullshit. Pardon my language. It's complete bullshit. And we have shown that there is no correlation with prevention of reducing heart attacks and strokes in the systematic review in BMJ evidence-based medicine. People look that up, me and 2 other cardiologists. We showed that this hypothesis that the lower your cholesterol, the better, is flawed. And actually, we can improve the cholesterol profile linked to insulin resistance and HDL and triglycerides, for example. But if we focus on insulin resistance, then the cholesterol profile improves. But total cholesterol and LDL itself, there should be for the overall majority of people, there should not be a public health drive to lower it for the sake of lowering it. Absolutely not.
It's so interesting to hear you say that, because I've talked to other cardiologists who agree. I've had them on the podcast, and I just need to get a cardiologist on the podcast who thinks that you need to lower cholesterol so we can have a respectable debate. Because, it's so interesting to me that so much of the population believes that cholesterol is bad. When I talk about including more nutrient-rich animal foods in the human diet, that's kind of the center of my message. I think the single most common question I get is, what about my cholesterol? Won't this raise my cholesterol? So over the last 80 years, the pharma industry, I'm not sure who is behind it, food industry has done a very good job of programming the general public, mostly through media, that cholesterol is bad, as you're saying. And there's this mass hypnosis of cholesterol lowering without really any attention or awareness of underlying metabolic health. I can't tell you how many people write to me or text me and say, I'm eating your diet, I'm eating meat and organs and fruit and honey, and I feel great, but my cholesterol is up. What do I do? And I'll ask them, did your doctor check a fasting insulin? And I don't think I've ever, not one time, heard of a quote, mainstream physician checking a fasting insulin. As physicians in the United States, and perhaps also in Britain, we're just not taught about how to contextualize the lipid panel. I love the way you're describing this, that your lipid panel can change, but just looking at LDL, HDL, triglycerides, and total cholesterol, that's just not the whole story. You just can't, I don't think you can make clinical decisions about someone's cardiovascular risk with those metrics. It's just, you can see them change in a way. And oftentimes, like you're saying, when someone eats more saturated fat from animals, butter, tallow, whatever, their LDL cholesterol, low density lipoprotein, may go up, but usually the triglycerides go down and the HDL goes up. And so, but physicians, at least the ones that I've come across peripherally, are so myopically focused on LDL. It drives me nuts.
Yeah, I think the way to describe it, certainly amongst physicians and members of the public, is the indoctrination is so deep on cholesterol being bad that even educated people think they're being objective. This is it takes time to overcome this, and that's what we've been trying to do for many years. But it's very clear. I tell you what's interesting as well, just to muddy the waters a little bit. Paul, a few years ago, I was also involved in a systematic review in BMJ Open, published in BMJ Open, where we looked at people over 60 to see was there an association of LDL cholesterol and heart disease. And the reason we looked at that, something that's forgotten from the original Framingham study, which started in Massachusetts in 1948 and went on for 30 years, which followed up 5,000 people. And we got lots of risk factors for heart disease from there, like smoking and high blood pressure and diabetes, and even high cholesterol. Is that once people, there was an association at very high levels of total cholesterol, like well over 300 milligrams per deciliter, right, which most people don't have. But once you hit sort of 50 or 60, as cholesterol dropped, mortality increased. So we thought, this is interesting. Is there something different in the older age groups? So we looked at people over 60 to find an association with LDL cholesterol and heart disease. One, there was no association. What was really interesting, though, there was an inverse association with all-cause mortality and total and LDL cholesterol. In other words, the higher your cholesterol, the less likely you are to die. And what's been forgotten in all this obsession with heart disease is actually cholesterol has an important role in the immune system. And older people are more vulnerable to dying from things like infections like pneumonia, for example. So it's probably a protective effect in the older groups. Separate to that, publication in BMJ just a couple of years ago followed up 100,000 people over around 10 years in Denmark. And they tried to find what was the optimal level of LDL cholesterol when it comes to longevity and lifespan. And that optimal level is well above what would get you a red flag from your doctor in terms of lowering LDL. So in UK terms, it was 3.6 millimoles per liter, which I think is about 140, between 140 and 160 milligrams per deciliter. That is actually considered optimal for lifespan. Now, just to tell you on a personal level, my LDL is lower than that. So I'm a bit concerned. So I'm proactively trying to increase my LDL. So I'm eating more saturated fat at the moment, Paul. Yeah, absolutely. My triglycerides and HDL are great, but I want to make sure that my longevity is better. So I'm trying to increase my LDL right now.
How interesting and slightly ironic that so many people in the longevity space are trying to lower ApoB. And let's just clarify ApoB versus LDL. ApoB is a lipoprotein found on low density lipoprotein, LDL cholesterol, which is a lipoprotein sort of balloon. It's a bus that carries cholesterol and triglycerides throughout the body. But ApoB is also contained on a few other particles, different types of ApoB on chylomicrons, VLDL, et cetera. But so when we're talking about ApoB, it's essentially synonymous with LDL at a high level. But there are many in the space, in the longevity space, who would say, no, you want your LDL, your ApoB as low as possible to optimize your longevity. It's just the discord here, the discordance is striking.
Yeah, just to explain, just to give people, to try and play devil's advocate, but we can counter this. One of the other reasons why people are so obsessed with lowering cholesterol is that I think when it comes to total and LDL cholesterol in general, 80% of it is genetic, right? You can influence the profile with diet. So people with genetically low cholesterol, Paul, certainly from Framingham, they didn't tend to develop heart disease, certainly up to the age of 50 or 60. There was no heart disease. So there is a presumption that because they had people with genetically low cholesterol or had low cholesterol didn't develop heart disease, we should lower it. And that doesn't make any sense because this Mendelian randomization we talk about means there could be other genes, and probably are, associated with low cholesterol that actually are the driving force between not developing heart disease and longevity, but it's actually nothing to do with the low cholesterol itself. And I think that's been, this has been a reductionist mentality. Now, with the best intentions, evidence evolves, people, I think those scientists genuinely believe what they were doing. But now we're well past that stage where there's so much evidence to debunk it. It shouldn't continue. The reason it continues is these powerful industries have profited from this flawed science, and then they control the universities and academics. Like most of the research funding now, certainly in nutrition science and in drug development, to universities comes from pharma or big food. So the people who are calling the shots, where ultimately are these powerful entities that lie for profit. We know that. But the problem is the public and doctors aren't aware of these system failures. They think that the guideline bodies are independent and they are rigorous, and that anything published in New England Journal of Medicine or the Lancet is gospel truth. when most published research findings, according to the Stephen Hawking-like figure of medicine, Professor John Ioannidis at Stanford, most published research findings are false or certainly misleading. And I think that's a discussion we need to start having. And that brings me back to something else very briefly on medicine, and is that this sociocultural phenomenon where people think that medicine is an exact science, that when it's not an exact science at all. It's an applied science. It's a science of human beings. It's a social science. It's evolving. It may be, one diet, as you were going to talk about, one diet for one particular person at a particular time may be good for them, but may be harmful for another. So I think there's a lot of nuance here that is lost. And that part of that is because of this lack of appreciation that actually good health ultimately doesn't come from a medicine bottle. Good health comes from lifestyle. And your doctor isn't somebody that ultimately is going to be you're not going to have the best health purely because of what your doctor tells you. Most of what determines your health happens outside the consultation room in the hospital. Absolutely. And I think we need to start with that discussion first, and then we can talk about uncertainties in evidence, what we think is best. And actually patients like that. They want that honesty.
I just want to highlight what you said there because it's so important. And this is fairly technical. So if this is confusing for people, just kind of skip past this part. But you talked about these Mendelian randomizations, which are abbreviated MR, and similar to that are genome-wide association studies, or GWAS. And Mendelian randomizations and GWAS studies are the evidence put forth by the people who are preaching that ApoB is a direct driver, is the proximate cause of cardiovascular disease. And you said it so well, you explained so well how they can be flawed. These are not studies that are looking at interventions, that they're looking at genetics, and they're looking at the association of certain genetic phenotypes. So a phenotype is the expression of your genetics. It's how it looks physically in the world. And some people have genes which lead to lower LDL cholesterol. And some people, as you mentioned earlier, have genes which lead to higher cholesterol. And the people on the high end are often considered to have familial hypercholesterolemia or familial hyperlipidemia. And as you said, many people, but not all people, in the familial hyperlipidemia cohort do tend to develop atherosclerosis. But there are many people in that cohort also who don't develop atherosclerosis. And often there are over 2,000, I think, genetic polymorphisms that can lead to FH, familial hyperlipidemia. You would know this better than I would. And so many of those have associated polymorphisms that you mentioned, either with at the level of the immune cells, the macrophages, which are in that subendothelial space, and they change the scavenger receptor in crazy ways. And so people with FH have an increased tendency to have these macrophages within our blood vessels consume the cholesterol and become foam cells, or they're hypercoagulable in so many ways. And on the other end, which you briefly mentioned, people with low genetic cholesterol may have polymorphisms which are not at all related to cholesterol, but maybe related to clotting or immunologic, the immunologic roots of how a plaque forms, how a fatty streak forms in the arteries. And so I think that you're so right. These GWAS, these Mendelian randomizations, which form the foundation of the ApoB argument, are inherently flawed. And I'm just going to keep trying to have this conversation with some of these ApoB proponents.
I mean, Paul, I mean, you raised something else that's really important there, is that we shouldn't, ultimately we need to treat the whole patient, not a biomarker, right? And I think the problem is people have thought incorrectly that, that because medicine may be an exact science, you've got a biomarker, you change the biomarker with the drug, automatically it's going to be beneficial. But actually, certainly when it comes to drug therapy, you have to look at the double-blinded randomized control trial, that if you do affect that biomarker, even if it's associated with the disease, does it make a difference? And that really gives you an answer. And certainly when you look at statin drugs, for example, which are one of the most prescribed drugs on the planet, it's estimated certainly statins are offered to about maybe 1 billion people in the world. I mean, that's an extraordinary figure. And I know in the United States, there's probably maybe at least 50 million people taking statins, maybe more. Is that what patients are not told is that when you break down the information on the benefits of the statins for what's important to patients, like preventing heart attack, strokes, death, for example, certainly if you are at low risk of heart disease, you've not already had a heart attack, or you haven't been diagnosed with severe coronary artery disease or angina or had a stent or a bypass, that kind of thing, then you have at best, right? This is still industry-sponsored data that's non-transparent, right? But at best, you have a 1% chance, a 1 in 100 chance that if you take that pill religiously for 5 years, it's going to prevent you having a non-fatal heart attack or stroke if you do not get side effects, but will not prolong your life. And really, medicine should be, and this is well documented from researchers in this field. I've been a big promoter of this. Is that actually giving patients information in this way is actually at the heart of ethical, evidence-based medical practice. You need to give patients numbers in a way that they can understand, which is free from coercion and manipulation of their hopes and anxieties. And that isn't done routinely. And part of, again, Paul, we weren't taught this at medical school, transparent communication of risk. So I think that highlights, if you like, what people should be really asking is that when a patient goes to their doctor, it should be, do I really need this drug? What are the absolute benefits and what are the absolute harms? What happens if I do nothing? And are there any safer or simpler alternatives? And of course, you and I know one of the most powerful alternatives to medications for chronic disease management is lifestyle change. And lifestyle change won't just improve your lifespan, most likely, but one thing it can do, which most of these pills cannot do, Paul, is improve the quality of your life.